What is depression? Why do we feel low, blue, or down? For the past 50 years, medicine told us that your depression is caused by low brain serotonin levels. It's a chemical imbalance, an aberrant biological mistake with a very easy pharmaceutical fix: antidepressants. Sertraline, citalopram, Prozac, these are names of antidepressants you would have heard, seen, or are taking. These SSRIs are designed to increase brain serotonin and reduce the experience of depressive symptoms. In 2022, Professor Joanna Moncrieff, an NHS consultant psychiatrist, concluded from her research that this isn't the case. The serotonin theory of depression is false and the chemical imbalance is inaccurate. She cites concerns around the over-medicalization of everyday mental health challenges into formal psychiatric diagnoses and being critical of how this theory of depression translated into evidence and everyday clinical practice. This is a conversation that deconstructs one of the largest mental health challenges facing our modern health services and asks us to radically reconceptualize the role we might think health services play to our mental health. This conversation is part of an ongoing academic debate between psychiatrists agreeing, disagreeing, and dissenting. This isn't a conclusive conversation with an easy conclusion. Almost 1 in 5 adults are taking antidepressants and experiencing benefits from them. This isn't medical advice or we seek direct care from a healthcare professional. This is about how some psychiatrists are challenging our long-held beliefs about the theory of depression. So without further ado, for Medicine Unheard, this is Professor Joanna Moncrieff.
I am a psychiatrist. I've been working as a psychiatrist in the National Health Service in London for about 25 years, and I am also an academic at University College London, and I've had a long-standing interest in the use of drug treatment, so that's medications like antidepressants for mental health problems. And I've also done some research on use of antipsychotics and lithium and other sorts of drugs. The book Chemically Imbalanced is particularly about depression and the use of antidepressants. And it started from a paper that I published based on some research that I did with some colleagues that was published in 2022, which looked at the evidence on links between serotonin and depression. And we looked at all the research in the different areas, the different types of studies that have been done, looking for whether there's evidence of connections over the last few decades. And we found that none of the areas of research provided consistent or compelling evidence that there was an association between serotonin and depression. There wasn't any compelling evidence for any sort of association, let alone the idea that low serotonin causes depression.
In the opening of your book, you talk about the profound impact of the narrative around low serotonin causes depression. You are taking on the medical establishment when you say there is no evidence to suggest low serotonin causes depression. What do you hope listeners take away about the human cost and the human stories behind this scientific debate?
Yeah, so I wanted to write this book because I am aware that most of the general public believe that a link between serotonin and depression has been established, that it is a scientific fact, whereas what it actually is a theory that was dreamt up in the 1960s and then popularized by the pharmaceutical industry, for which there is a little bit of positive evidence, but quite a lot of negative and inconclusive evidence. Many people in the psychiatric community actually know that's the case, but they haven't, but that hasn't been publicized, partly because there's so much research in lots of different areas and no one before had got it together. So you got it all together in one place, and therefore being able to sort of take an overview, as we did when we did our research and published our paper. And the reason it's important is because this idea that people have come to accept as a fact that depression is caused by a chemical imbalance has persuaded many, many people that the sensible way to treat depression, to deal with depression, is to take a drug that they have been told targets this underlying chemical imbalance. And because people have been led to believe that this is true, this is all established by good evidence, they have not appreciated that actually what you're doing when you take an antidepressant is not taking something that has been proven to correct an underlying abnormality or an underlying mechanism that leads to the symptoms of depression or anxiety or whatever it is that you have. What you're actually taking is a drug that crosses the blood-brain barrier, that changes the normal state of your brain and therefore changes your underlying mental activity, including your feelings, your thoughts, and the way that you behave. In the same way that if we have a drink of alcohol, or in a much subtler way, a mug of coffee, that also changes the state of our brain and changes our mental state. The changes that are produced depend on the sort of drug that you take and how it affects the brain exactly. And the changes that antidepressants produce are not the same as the changes produced by alcohol or caffeine or any other sort of psychoactive drug. The changes that antidepressants produce actually are quite varied because antidepressants themselves consist of many different sorts of chemicals from many different chemical classes. But one of the effects that antidepressants have is that they numb or dampen down the intensity of emotions. And so people may not feel so acutely depressed or anxious anymore, but they also don't feel happiness or joy or excitement or positive emotions either. And of course, if you're in that slightly dampened state, then your underlying feelings change. And if you're in a depression trial and you're filling in a depression questionnaire, your levels of depression may register as lower than if you weren't taking your antidepressant. Although, having said that, when you look at randomized controlled trials of antidepressants, they are actually barely different from a placebo. So even though they do have this emotion dampening effect, it's not clear that it actually is helpful in terms of improving the symptoms of depression or anxiety or any other mental health problem for that matter. But I think it's still important to appreciate that antidepressants are drugs. They change the normal state of our brain. They change our underlying feelings. And when you put it like that, it's clear that they may have some untoward consequences. If you're, messing about with the normal state of the brain, and we don't quite understand how they do that. We don't quite understand what sort of changes they're producing. They probably do. Some antidepressants probably do increase serotonin activity temporarily, but then there's some evidence that actually in the long term they reduce it, and they're probably likely to be affecting other brain chemicals and other brain processes, partly because serotonin is involved in lots of brain processes and partly because they're unlikely to be that specific. So when you're messing about with the brain in that way, there can be untoward consequences. And one of these is that the brain tries to resist the impact of the drug and it adapts to its presence. So when you stop it, you experience withdrawal symptoms. And we're familiar with people experiencing withdrawal symptoms when they stop alcohol or opiate drugs, benzodiazepines like Valium and Librium. And withdrawal symptoms after stopping antidepressants have been recognized going back to the 1950s, actually. But they've been reported more and more frequently by people who've come off antidepressants over the last couple of decades. And it's become apparent that for some people, these can be really very significant. They can be severe and they can be prolonged for weeks, months, and sometimes years in some people after they've stopped taking the drug, probably particularly if they've stopped taking the drug suddenly and the brain hasn't had time to sort of adapt to reducing doses. And so this just illustrates, I think, that when we put in a foreign chemical into the brain and we're not sure what it's doing, it can cause harm. And so withdrawal effects and dependency are one type of harm, but there are other harmful effects, particularly on sexual functioning. We know that antidepressants cause sexual dysfunction while people are taking them, but it's also become apparent that in some people, the sexual dysfunction persists after they've stopped taking the drug. And obviously this is very worrying, particularly because more and more young people are starting to take antidepressants. And often we know that people who start drugs often end up taking them for years. These effects are probably more likely after people have been taking the drugs on a long-term basis, although they are also reported after short-term use very occasionally. And this sexual dysfunction, also this persistent sexual dysfunction that some people are reporting, also seems to be associated with persistent emotional numbing. Just to add to that, this has also been shown in animal studies. It's been shown that animals who are given antidepressants and then the antidepressants are stopped show a decrease in their normal sexual activity subsequent to stopping the antidepressants, as well as while they're taking them in some cases. So this is not just a case of people who've become depressed again, reporting depression-related sexual dysfunction. It does seem to be a pharmacological effect of the antidepressants. I mean, people who have this persistent sexual dysfunction and people who are in a protracted withdrawal state, which, as I said, sometimes can go on for months or years, can be in a really debilitated and disabled state. And, you know, imagine if you're a young person and your sexuality is suddenly taken away or, you know, significantly suppressed. That's a very big deal.
It's extraordinary listening to this and then trying to appreciate how we even got into this situation in the first place. You write in the book, for more than 3 decades now, people have been misled about the origins of depression and what antidepressants do. Given the scale of SSRI prescribing, and it's definitely perhaps one of the most prescribed drugs in psychiatry, but also perhaps I think in general medicine and primary care, the persistence alongside the delivery of this drug that there is a chemical imbalance, this is a rebalancing of your brain chemistry. Do you see this as a failure of science communication and research advocacy and research literacy? Or is it perhaps more nefarious, a deliberate campaign by pharmaceutical interests? Or is it something more systemic within medicine with our unwillingness to critically analyze ourselves and our alliances and what the evidence sort of concludes to be? How do you respond to the medical establishment collusion, as it were?
It's all of those things. So definitely this idea that depression is due to a chemical imbalance was promoted by the pharmaceutical industry very strongly in the 90s in order to sell SSRIs, essentially. And not only did they promote this message, they clearly set out deliberately to suppress people's previous inclinations about the nature of emotional problems. So there were some surveys done in the early 90s that showed that people, if you ask people, is depression a, biological condition? Some people agreed, but most people didn't agree with that. And if you ask people what were the causes of depression, most people would say divorce, unemployment, child abuse, and things like that. And most people at that time felt that taking a drug to manage your emotional problems was not a good idea, partly because of the problem of dependence and partly because they felt that the drug would just sort of numb people or cloud people's mind rather than really dealing with the problem. So the pharmaceutical industry set out to change that mindset very deliberately, to persuade people that was the wrong way to think about emotional problems, that we should think of them as diseases, as proper medical conditions that required drug treatment to rectify them. And that those campaigns were incredibly successful and persuaded the general public that this, that depression was a chemical imbalance, as this was a scientific reality, not just provisional theory that had been conjured up back in the 1950s when people started experimenting with giving drugs to people who were depressed. So the pharmaceutical industry campaigns are definitely part of the picture. The medical profession have gone along with that idea. They, as I said earlier, many members of the medical profession actually knew a long time ago that the evidence for a serotonin deficiency in depression was very minimal, but very few people actually stood up and said that. And many medical institutions, such as the Royal College of Psychiatrists in the UK, the American Psychiatric Association in the US, have put out information to people suggesting that depression is due to a chemical imbalance, or they might say depression might be caused by a chemical imbalance, but because that's been said so many times, people interpret that as meaning that there is, a good body of evidence to suggest that that's the case, not just that this is an idea that we've had, but actually the evidence doesn't support this at all. So the pharmaceutical industry have promoted this idea. The medical profession have gone along with it. They've actually put out material to support it, and they certainly haven't stood up and told people that this idea is actually incorrect and not an established scientific fact. And think both of these things have probably played into a natural inclination that people have to embrace medical solutions to complex problems. I think, as I said, I think people do have a wariness about, an underlying wariness about taking drugs to deal with emotional problems. But if someone comes along and says, there's an easy solution, it's a pill, this is not a complex problem about your life and your personality and your situation that you need to get to grips with. It's just a chemical imbalance in your brain. We've got a pill here that can put it right. Of course, that's a seductive message. Of course, people are, some people are going to go along with that. So I think all these factors have fed into this situation where we have this very wide scale prescribing of antidepressants. Almost 1 in 5 people in the population now take antidepressants in the UK. I mean, that's unbelievable numbers. And many of those people end up on, half to 2/3 of those people end up on antidepressants long term. That is, they end up taking them for more than a year or a couple of years. Many people end up on them for 5 or 10 or even more years.
It's extraordinary. I really want to get into the central thesis and claim of your idea, because we almost forget what you're really trying to advocate and say. And I had an aha moment in particular. On page 33, you note that there are 2 versions of depression, and the second version of depression is that it's different from normal feelings. The implicit latent idea in the serotonin theory of depression, that there is brain chemistry imbalance, is that is a pathology. That is not an emotion. That is not a spectrum of emotion. That is particularly a disease and a pathology. And it's entirely separate from all other forms of human emotion that requires remediation, that requires intervention, which was quite extraordinary when I thought about it. How do you think our cultural and clinical narratives about depression have contributed to this conceptual divide? And what are the consequences for how we treat and support people in distress? When you laid it out in the book, you almost feel the fallacy and the folly of it. If there's chemical imbalance that from it emerges depression, what is the chemical imbalance that gives me euphoria? What is the chemical imbalance that gives me total immobilizing fear?
Yeah. So this idea that there is such a thing as depression, and that it's clinical depression or major depression, and that it is somehow distinguishable from our ordinary emotions is pervasive now, and has been thoroughly promoted, strongly promoted by the medical profession, particularly by psychiatrists. And you hear it again and again and again, this idea that, we're not talking about ordinary sadness. We're talking about a medical condition, a recognizable medical condition that needs medical intervention, whether that's drugs or some sort of therapeutic input or whatever. And the idea that you can cut off ordinary emotions from pathological emotions is just completely untrue, and it's not how the world works. People who get diagnosed with depression are people who go to see their doctor because they are unhappy in their lives in one way or another. They may be very unhappy. They may be really distressed. They may be in a really bad way. But there's nothing categorical that distinguishes them from someone else who is unhappy but doesn't go to their doctor. There's nothing that says that going to your doctor with emotional problems makes you more severely unhappy or more clinically depressed than not going to your doctor. And there's nothing that the doctor does when you're in the consulting room with them that distinguishes between whether you've got a clinical condition or you haven't got a clinical condition. We know that different doctors will have different thresholds for diagnosing people with depression or anxiety or anything else. Some people will diagnose and treat and give antidepressants to most people who come through the door who are distressed. And some GPs and other doctors will try very hard not to do that, and to encourage people to wait and see and not label that condition as a medical condition. It depends very much on the doctor you've got, their point of view, their state of mind on the day, the way that the individual patient presents. All these things are going to contribute to whether or not someone gets a label of depression or not. And none of them involve a scientific test or any sort of objective test. They're all very, very subjective things. So I think that's a really important point to debunk. I mean, if you take the official version, so the official The official version is that, you know, people who fulfill certain criteria in our diagnostic manuals have clinical depression, and people who don't fulfill them don't have clinical depression. But these criteria are they're just lists of possible symptoms or possible difficulties that people might have. They don't have any scientific validity. The questions are, you know, are you depressed or not? Have you lost interest in your usual activities? Are you having difficulty with sleep? I mean, all these things are very common experiences, and there is no scientific way of dividing someone who is having what might be regarded as an understandable reaction to you know, having a relationship breakdown, and someone who is having a more prolonged and profound episode of low mood. There's no hard and fast dividing line. And I think it's important to say that this also applies to people who have really severe depression. And I'm not trying to say by this that the depression can't be severe. You know, we are all different, and people have different sensitivities, different inclinations to get into various sorts of mood states. Some people are more likely to get depressed and anxious than other people, and some people get into very severe depressed mood states. There is still no evidence of any physical mechanism behind those severe mood states. And it's also the case that in most cases, there is something that people are reacting to. So, for example, you often see this quite sort of severe depressive picture in elderly people, and it often comes after retirement or bereavement. So they can get into a, you know, really severe state. Sometimes they stop eating and drinking. Sometimes they have some delusions, but it's still most frequently a reaction to something that has happened in their lives, and therefore at some level an you know, understandable and meaningful state rather than a meaningless biological state.
So we've pathologized unnecessarily so, perhaps, normal distress that can be in variance of its levels that patients experience. And in pathologizing it, there's that diagnosis element of it, of receiving the diagnosis of depression. And you talked about it in your book, and it was my second aha moment. And you said psychiatric diagnoses are very different from receiving another diagnosis. In fact, you actually challenge the very notion of receiving a psychiatric diagnosis. You write, a psychiatric diagnosis is like diagnosing someone as having a headache. It just names the symptom the person has described. Depression, like you say, is a symptom of external emotional stresses, triggers, whatever else it is that is causing you to have low moods, low arousal, whatever else. How do you think diagnostic labels for depression and related conditions shape individuals' identities, expectations, and their process of recovery? And most importantly, perhaps, what would be a more honest and helpful approach of a diagnosis of depression in medical practice?
Yeah. So that's a really good question, and this is a really important point, because I think people fundamentally misunderstand the nature of a psychiatric diagnosis. And that's quite understandable, because the term diagnosis implies that you have identified the cause of something. You know, when you go and see a doctor because you've got a headache, you don't expect to be told you have a headache. You expect to be told the cause of your headache or the cause of your cough or whatever it is. The headache and the cough are not diagnoses. In psychiatry, we are using the problems that people express as diagnoses. So someone comes along and says, I feel unhappy, and we're saying, oh, you have depression, as if this is a physical condition inside the person that can be treated separately from the person themselves. Whereas I would argue that depression is a state of a person. It's not something that can be separated. It's something, the way an individual feels, and it is by definition a reaction to someone's circumstances. So people are fundamentally misunderstanding what diagnosis means. Diagnosis is just a decision to call the problems that you are currently experiencing by a certain name. So you go and see your doctor and you say, I'm feeling unhappy and I can't be bothered to get out of bed at the moment and I'm not enjoying anything. And the doctor's saying, okay, let's call this depression. They're not saying, I know that you have something going in your body that explains the symptoms you've just described to me. That's not what's happening in that situation. What is happening is you're just describing how you feel, and you and the doctor are agreeing on what to call it. And that is why, if you went to the doctor back in the 1950s and said you weren't happy with your life in various ways, you would have been labelled with anxiety. You would have been diagnosed with anxiety. If you went to see the doctor in the 1990s with the same problems, you would have been labelled or diagnosed with depression. If you go and see the doctor with the same sort of symptoms nowadays, you may well get labelled with ADHD or bipolar disorder or a number of other disorders that have broadened out and become more widely applied recently. And I think that just highlights how what we're doing is we are labelling distress in different ways. We are not getting to the cause of the problem. And in fact, I think we're often obscuring the cause of the problem. So when we say, oh, what you've got is depression, then the implication is, okay, we're now not treating you as an individual with your particular problems. We're treating depression, or we're treating ADHD or whatever. And this requires a drug, often a drug treatment, but it might be a therapeutic intervention as well. But what you're not asking by doing that is, why are you feeling like this? What are the problems that have led you to feel like this? And how can they be addressed? Because that's what really needs to happen.
Again, quite extraordinary. So we've now reached a point where we're pathologizing normal distress. We're now prescribing a drug, most likely SSRIs, selective serotonin reuptake inhibitors, because we think that your brain serotonin is low, so we want to increase it. You describe in your book two predominant ideas in the research community that explains what these drugs that we're so happily prescribing do. And you contrast the disease-centered model of drug action, where drugs, and like the narrative says, is that they're correcting a biological abnormality, with something that I didn't hear before and you alluded to in the beginning, the drug-centered model, which is that these drugs are mind-altering substances, and perhaps that's what's explaining what we're seeing. Could you just explain a bit more about the models and the differences between them, and why this drug-centered model of drug action is quite extraordinary and crucial to your debunking of the serotonin hypothesis?
Yes. Absolutely, and thank you for giving me the opportunity to do this. I've been describing these models since 2005. That's when I first published a paper on them. My goodness, 20 years ago. And I think it's so crucial and difficult to challenge. And I also I think that it gives people a new perspective on drugs, which is really informative and empowering. So the disease-centered model is the traditional idea that what drugs like antidepressants are doing is they are helping to cure depression or improve depressive symptoms by rectifying or by targeting the underlying mechanism, the underlying biological mechanism, whether that's a chemical imbalance, one of the most popular theories, or some other sort of mechanism that leads to the symptoms, some other sort of biological process, abnormal biological process that leads to the symptoms. And what I've been highlighting is that we actually have no evidence that any class of drugs that we use for mental health problems works in that way. And most medical drugs do work in that way. Even if we think of painkillers clearly aren't working on the ultimate cause of the disorder that's causing you pain, saying you're getting pain from rheumatoid arthritis. They're not necessarily curing the rheumatoid arthritis, but they are working on the mechanisms that produce pain. So they are working on the mechanisms that produce the symptom of pain. The same with your asthma inhaler. That doesn't cure asthma, but it relieves wheezing by working on the mechanisms in your lungs, by relaxing the constriction in your lungs, which is leading to the wheezing. Psychiatric drugs don't work in that way, even in that symptomatic way, because we have no idea what, if any, mechanisms produce emotional symptoms like depression or anxiety. But they are active drugs, and they cross the blood-brain barrier, and they change the normal state of our brain, and by doing so, they change our underlying mental processes, and therefore they change our feelings, our thoughts, and our behaviors. And of course, these changes will impact on how we are feeling at the time. So it's just as if you had a glass of alcohol or caffeine, as I was saying earlier, that's changing the normal state of the brain. It's making you feel different. If you're unhappy and you get very drunk, for example, you are likely to temporarily forget your unhappiness, or your underlying feelings will temporarily be replaced by this state of intoxication induced by the alcohol. And psychiatric drugs like antidepressants are doing the same thing. They're not exactly the same thing because they're different drugs from alcohol, but they are changing our underlying mental states by changing the normal state of our brains. And those changes occur in anyone. So this emotional numbing that antidepressants produce has also been shown to occur in volunteers, for example. So this is not something that's specific to people who have depression or anxiety. This is just a general effect of antidepressant drugs, that they numb emotions. Obviously, if you take a drug that has that general effect and you are feeling intensely depressed or anxious, it's probably going to numb you out a bit and reduce the intensity of those feelings. And that may be perceived as being helpful by some people in some situations, although I should caveat that with the observation that actually a lot of people find that emotional numbing effect to be really unpleasant. They don't like it. But in theory, it may be helpful for some people. And it is also likely to be one of the explanations for why there is a small difference between antidepressants and placebos in randomized controlled trials, although that difference is very small. And I think there's another explanation for that, and that is that people in randomized controlled trials can often guess whether they're getting the real drug or the placebo. And we know that what people guess they're taking has an effect on their outcome, has quite a strong effect on their outcome, because people expect the antidepressant to help them. That makes them hopeful, and therefore they do better. So I think that's probably one of the main explanations for the very small difference between antidepressants and placebos in clinical trials. But the emotional numbing effect may also be contributing to that. And I think this is really important, because if you've been told that you have a chemical imbalance in your brain and we have a drug that can put that right, it obviously makes sense to take it. You might be put off by side effects. It doesn't mean you necessarily must take it, but it sort of inclines you towards taking the drug if that's what you're told is the case. Whereas if you're told, we don't know what's going on in your brain, what you're feeling is probably related to your circumstances, what we have are drugs that will numb you by altering the normal state of your brain, then obviously that's a different prospect from taking something that's a corrective that's going to normalize the state of your brain. It's a different prospect, and it's more worrying. And it highlights the negative effects that we've just been talking about that can occur when people take antidepressants. It makes those that negative consequences may occur from taking these substances. And so I think, had people not been told repeatedly that they had a chemical imbalance or that depression was caused by a chemical imbalance, they would probably have been much less inclined to take antidepressants than they were.
It's really interesting that you're talking about the more open, honest, and sort of uncertainty embracing conversation that doctors can and should have, which exposes perhaps or just lays out the side effects that you may experience and the uncertainty around the mechanisms of action that these drugs have. Again, when I was thinking about this, it's quite extraordinary if doctors, and I imagine they do actually quite fall into the narrative telling a patient you have low levels of serotonins, these drugs will help you, without ever objectively, empirically measuring a person's serotonin levels or having direct evidence of its deficiency in an individual person. That's quite an extraordinary claim for a doctor to make to a patient. We know why this narrative has persisted for so long. You've already answered that. What does it reveal about the role of uncertainty and authority and reassurance in medicine? I think that is something that's quite key, especially in psychiatric diagnosis, especially when it's becoming more prevalent, when we're seeing, is there an overdiagnosis of autism? Is there an overdiagnosis of ADHD? What's happening? How can doctors revel with uncertainty in their clinics and practice?
The doctors want to help people, don't they? And I think it's really difficult when doctors are confronted with problems for which there is no obvious help or easy answer, and for which medicine is not particularly appropriate. And so I think part of the problem is that, because of all these pharmaceutical industry campaigns, people were encouraged to go to their doctor with emotional problems. What do doctors have? What do doctors do? They have drugs, they have prescription pads. So, inevitably you're going to end up with a situation where we get the overprescription of medicines. And I think that doctors have probably have got more used to dealing with uncertainty in the era of evidence-based medicine. When I was a medical student, for example, the doctor or surgeon or whoever you were attached to said how things were and you didn't question it. And if you questioned it, you were being a bit disobedient and rebellious. We're now, as doctors, I think, mostly used to asking questions and expecting to have answers in terms of evidence. If we say, why do we do that? Then the answer should be, well, there's this evidence and this evidence that supports this and, shows that the outcomes are this, that, and the other. So I think one of the problems in mental health is that we have got a lot of trials, but the question is really, how good are those trials? What are they actually telling us? What does a trial comparing an antidepressant and a placebo really indicate? Can we even measure depression? I mean, does it even make sense to measure an emotional state? I think that's a big question. I would argue that it doesn't really. These are not quantitative things. This is not like blood pressure. And our measures of depression, for example, one of the common measures of depression, the Hamilton rating scale, it rates you, if you volunteer that you're depressed, you're rated as being more depressed than if you don't. So someone who comes in sort of, and distressed and, says how terrible they're feeling will be rated as having much more severe depression than someone who is, for example, who might be in some ways much more disabled, who, is maybe very withdrawn and what we call retardation of movements and things, and can't express themselves very well. They might score as actually being less depressed because they're not actually expressing how they're feeling underneath. So that's just all to say that the measurement of depression is artificial and unreliable, and therefore all the trials that we have, even though we do have a lot of trials looking at antidepressants and other forms of treatment for depression, are not necessarily telling us anything very reliable or very helpful. But we are used as doctors to going to the evidence and looking for an answer there and condensing that evidence in such a way as to say, well, okay, this treatment works for this. So instead of, and of course it is quite a long and complicated thing to explain to people that we have this evidence, but actually we're not sure what depression is. We're not sure how you measure it. We're not sure how to test out antidepressants. We're not sure what's happening when people take placebos or what these differences between placebos and antidepressants mean. We're not sure who goes into these studies in the first place. So there are just so many questions about the evidence base in mental health that I think it's difficult for doctors to even know where to start if they're going to really communicate about all the uncertainty that is embedded in that evidence.
What would an honest conversation sound like in a clinic of a clinician explaining to them the idea of perhaps having depression and sort of navigating a tension of wanting to help, but also acknowledging what you've just said, the various uncertainties of what we don't know as well? So what would be that sort of script that you would say, this is what we should sort of be saying to our patients?
So I think there are two parts to that question. The first part is that if you understand depression not as a disease, not as a thing that people have, but as a way that individuals react to their lives, then the most important thing is to help someone to identify what's gone wrong in life, what they need to change. So that's a really important part of the conversation. That's the most important part of the conversation, in my view. But the other part of the conversation has to be to manage this medical framework that we have constructed around these situations. The first thing I think is to say to people that some people in your situation might say that you're depressed or give you a label of depression. And then I would explain to people that this is a label. It doesn't imply that we know anything about what's going on in your brain. And indeed, we don't have any evidence about links between depression and brain chemicals or any other brain mechanisms. And I would also explain to people that although some people find these labels to be helpful, some people find them to be unhelpful. And there's some evidence that labeling people can lead to bad outcomes in itself, because it can be a sort of self-fulfilling prophecy. People can think, oh, I've got this condition, this biological condition, this disease, this medical thing, and therefore I don't have control over my life. Therefore, I need to rely on medical interventions. This is not something that I can influence. So I would have a conversation about the meaning of labels, and then I would have a similar conversation about the use of antidepressants. If I felt that someone was in the sort of severe state that would mean that most of my colleagues would be offering them an antidepressant, I would have a conversation that goes along the lines of, many people would suggest that you should be prescribed an antidepressant in this situation. And some people think that the evidence shows that these are beneficial. My view is that the differences between antidepressants and placebo are small. There is no evidence that these are targeting or rectifying any underlying chemical imbalance or any other process that's going on in your brain. They are drugs that do change your brain, and that does come with possible negative consequences and can have harmful effects on your health in the future. They are drugs that do seem to numb emotions through the alterations they produce in your brain. Some people might find this to be helpful. Some people find it unpleasant. If you think that it's something that you really need to do, having been informed about all the adverse effects that might come along with it, then I would always be advising people to take antidepressants at as low a dose as possible for as short a time as possible. I think that's a really important thing, because the adverse effects like dependence and withdrawal symptoms seem to be associated with longer duration of use. And so if people can, use an antidepressant as some sort of sticking plaster for a few weeks, that's going to, and then stop them, that's going to massively reduce the proportions of people who end up taking them long term and have lots of negative consequences from doing so.
Some of your critics argue that your work risks undermining trust in psychiatric care, medicine, and the health profession generally, and could just discourage people from seeking help, because now we know that a vast sort of swath of the medical establishment is inappropriately perhaps in prescribing antidepressants, imperiling patient health and well-being. How do you respond to those concerns? And I guess, what do you see as your responsibility in this public debate?
So in two ways. The first is that we do actually have a lot of non-medication based alternative ways of helping people with anxiety and depression. We have a national therapy service in this country, which has a short waiting list, but not a huge waiting list for most people for the sort of first basic level of therapy. And we also know that things like exercise and mindfulness and problem-solving therapy and things like that are all helpful for improving people's mood. So there are other things that we can suggest. We don't have to go down the medication route, and therefore we can still be trying to help and support people with depression, as well as trying to identify their individual problems, as I mentioned earlier. So that's one thing. But a second thing is that this does highlight, I think, a broader problem. We have encouraged people who don't have medical problems, or what are fundamentally medical problems, to go to their doctors to get help. And that's not really a sensible situation. We need a different sort of service for people who have what we call mental health problems. I would suggest that we need services that are located within social services and are linked to the sort of services that can help people with the problems that that most frequently make people anxious and depressed. So we need services that are linked up with financial advice and debt advice services, for example, with relationship counselling services, with employment advice services, with housing services. Those are, some of the very frequent things that people are struggling with that lead them to have problems with anxiety and depression. And so we need to be restructuring our services and providing a more appropriate situation for people who have mental health problems to go and get the treatment that they need.
You've taken a stab at the medical establishment, the medical workforce. We have the future health workforce listing current students for future health professionals. If you could redesign the system, because this seems to be a systemic issue that's enabled this inappropriate prescribing of a drug that we don't know how it works. If you could redesign the system from scratch, how would you conceptualize diagnosing, treating depression? You've already said that we need services that are social services, but what would you keep? What would you discard? And what would you build in its place? What would the ideal service look like?
Might need another podcast to address all these issues. I mean, I think for the vast majority of mental health problems, we need a service that is located outside of medicine, that really thoroughly demedicalizes these problems. We also need to massively curtail the activities of the pharmaceutical industry and do more to make transparent, at the very least, and hopefully reduce the links between the pharmaceutical industry and the medical profession, which have led to the overuse and all the negative consequences of that, of drugs like antidepressants.